Hello everyone. Today we are going to see about upper limb. Let's start with medial epicondylitis. It is also known as golfer's elbow. Why? While playing golf, the entire upper limb is in contact with the body. So during that time, that part which is in most contact is the medial epicondyle. So what are the two muscles which arise from medial epicondyle? What are the two muscles which are inflamed in medial epicondylitis? They are the flexor carpi radialis as well as the pronator teres. So inflammation at flexor carpi radialis as well as pronator teres will result in medial epicondylitis. That's all. So since this is inflamed, the major action of this is flexion. So at the wrist. So the patient will complain of elbow pain when there is wrist flexion against extension. So when you ask them to flex the wrist against extension, they will be complaining of pain not at the wrist but then at the elbow, that is at the medial epicondyle. In that way you can understand that they are suffering from medial epicondylitis. So this is the pronator teres and this is the flexor carpi radialis. So they are the two, that is the tendons of these two muscles are the ones which are inflamed. What is the treatment? The treatment is forearm strap. How does forearm strap help? This strap is generally worn around the forearm just below the elbow. It will apply gentle pressure to the muscles and the tendons, which will reduce the strain on the medial epicondyle, where the tendon is inflamed and causing pain. So since the strain is reduced, since the strain is being redistributed, it gives a better chance of the body to heal by itself. What about lateral epicondylitis? It is the same, where the inflammation happens at the extensor carpi radialis brevis tendon, which arises from the lateral epicondyle. So again, the extensor carpi radialis brevis, the main action is extension of the wrist. So when the patient is asked to extend the wrist against flexion, then there will be pain at the lateral epicondyle. This is known as a lateral epicondylitis. So here they will, in both the conditions, they will be asking you what is the tendon of the muscle which is inflamed. Extensor carpi radialis brevis is the most favorite for MLE exams. Again, here too, it is a management is conservative with a forearm strap, which will decrease tension on the tendon of the affected muscles, thereby helping to heal the inflamed tendon. What about radial head subluxation? Radial head subluxation is where the radial head comes out of the elbow. Fine. This is also known as nursemaid elbow. So this generally happens when the child is having his arm pulled, or they are be running with older siblings and the child falls, resulting in the elbow pull. So elbow pull in the sense the radial head gets subluxated away from the elbow. So here the arms are kept pronated and also partially flexed. So this is how the child will present to you, and they will be refusing to use the arm. So what is the treatment? The treatment is either hyperpronation or supination. When the arm is partially flexed, either of these two maneuvers can help to correct the radial head subluxation. So mostly either one will be given in the exams and you will be asked to choose them. What about olecranon bursitis? This is the olecranon bursa. Fine. So the inflammation of this bursa is the bursitis. It is known as the olecranon bursitis. Usually this will follow contact injury, or when there is a repeated pressure, then the olecranon bursitis happens. So since a bursa is something which is localized and confined, they will present with the painful fluctuant swelling at the posterior elbow, and limited range of motion is also common. Treatment will include compression bandage and NSAIDs. Steroid injection is totally incorrect in MLA exams. What about primary hip dysplasia? As the name says, primary hip dysplasia. There is a developmental dysplasia of the hip. So what part of the hip is not developed properly? The acetabulum. there is poorly developed acetabulum, leading to hip instability in infants. So, when a child is suspected with this, the initial diagnosis is with ortolany and Barlow's maneuver, where there will be a clucking and clunking sensation. So this is pathognomic. When the ortolany and Barlow maneuver is positive, in that case, the next step is that we need to send the patient for a ortho referral. This they will ask you in step 2 CKA USMLE exams. So even though it sounds wrong, right? So the next step looks like we need to do imaging, but the next step is ortho procedure. After that, the imaging has to be done. What imaging should be done? If the child is less than 6 months, then hip ultrasound is the technique. If the child is more than 6 months, then hip X-ray can be done. So once the primary hip dysplasia, that is developmental dysplasia of the hip, is confirmed, the treatment is Pavlik harness position, where the legs are kept in a frog leg position and the harness is applied to promote the development of the acetabulum. What is known as leg calf perthes disease? Leg calf perthes disease is nothing but there will be idiopathic avascular necrosis of the femoral head. There is avascular necrosis, but the reason should be unknown. If the reason is known, say for example, the avascular necrosis is due to Gaucher's disease, or it is due to sickle cell disease, or it is due to corticosteroids, then the diagnosis is just simply avascular necrosis and not leg calf perthes disease. So this generally happens in a child who is 5 to 8 years old with hip pain. The other thing you should know is there should be no history of viral illness, because in the previous video you would have already seen where there is a term called diagnosis called toxic or a transient synovitis, which will follow viral illness. Now, the next step is the hip X-ray. When you suspect a child that is around 5 to 8 years with leg calf perthes disease, the next diagnosis is hip X-ray. In hip X-ray, there will be a flattened or contracted femoral head. When you hear the term contracted, it is high yield. It almost always means there is an avascular necrosis and which points towards leg calf perthes disease. Another thing is, since this is only avascular necrosis of the femoral head over here, sometimes the X-ray may not be sensitive to pick up it. So in step 2 CK, they might ask you if the X-ray is negative, then how will you confirm the diagnosis? Bone scan or MRI can be done to confirm the diagnosis. How do you treat it? Ultimate management is hip replacement, because there has been necrosis of the femoral head, isn't it? So that is a treatment for leg calf perthes. What about a slipped capital femoral epiphysis? Here, what does the term slipped capital femoral epiphysis mean? Here, the head of the femur, that is the ball part of the hip joint, will slip off the neck of the femur, where the head of the femur and the neck of the femur are connected at the growth plate. That is, the middle part is the growth plate. That is the epiphysis. When the head is slipped of the neck, then the term slipped refers to the displacement or the shifting of the femoral head. So that is the slipped capital femoral epiphysis. At the epiphysis, this is getting slipped. So this is what you should know. So why does this happen? This happens because of many reasons. One of that is overweight, but overweight is not always, but mostly it is due to hormones. So slipped capitofemoral epiphysis will occur in a 10 to 13-year-old pre-adolescent, mostly overweight boy with the painful limp. So then they might ask you, right, the mechanism of this, the reason behind this. That is nothing but the displacement of the epiphysis of the femoral head. Fine. Okay. Then how will the patient present? The patient will present with a painful limp. The diagnostic feature is age, because the most common reason is pre-adolescence, that is 10 to 13 years, and not necessarily the weight. What is the treatment? Surgical pinning is a definitive treatment, because we don't want the slippage to happen again. What is how will the X-ray be? X-ray will show as if an ice cream falling off the cone appearance. What about a trochanteric bursitis? In a trochanteric bursa is nothing but it is a bursa over here. That is at the hip joint, that is at the hip. So how will the patient be? They will be having a lateral hip pain which is worsened with palpation and when lying on the affected side. So they will be having a pain when ambulation, they will be having pain when stair climbing, they will be having an altered gait, they will be having a pain when lying on the affected side. So the primary treatment is NSAIDs because it is a bursa. Let's see about septic bursitis. In septic bursitis, here the concept is this, that is, there is bursa inside the joint and that has been infected. Fine. So the joint per se, there is no problem. Only the bursa is infected. So there will be no joint effusion. You understood? Only if there is any problem in the joint, then there has to be a joint effusion, right? But here only the bursa is affected, so it is bursitis. And it has been infected, so it is known as a septic bursitis. They will be having erythema, warmth and tenderness over the affected bursa. So they will be giving like over the affected tendon, I mean over the affected joint. But you should also know that they are indicating that the bursa which is inside the joint is been affected. So to distinguish it, the questions will very clearly say that there is no joint effusion, or even in a patient you can very clearly notice that there is no joint effusion. So systemic symptoms may appear because of the infection and because of the bursitis. That is also there. So that should not confuse or cloud your diagnosis from distinguishing septic bursitis from septic arthritis. So again, since this is inflamed, I mean since this is infected and inflamed, antibiotic therapy is the primary duration. With this, we have come to the end of our presentation, and I hope you had some concepts cleared with this thing. I have a good news for you. I am starting from mentoring lessons for medical students as well as USMLE aspirants. I am Dr. Veena. I am an anesthesiologist. I help people to clear their exams, and I love to teach and connect with people. So if you like my videos and if you want to get mentored by me, go ahead, send a message in the comments and I will get back to you. Looking forward to see you succeed. Have a good day.